Welcome back to the Physical Therapy San Pedro podcast. This is episode 68, and today we're discussing shoulder impingement, why athletes develop shoulder pain. I am your host, Dr. Janae Brown, and I am joined by my sports physical therapy team. To my left is
Dr. Silverton.
And to my right,
Dr. Bay.
Okay, guys, so we're diving into shoulder impingement. Dr. Bay wrote this blog and came up with this topic. She loves it so much.
And so second time.
This is her second time writing about it. So she should be very well versed in this topic. And we should just be riding along. Me and Dr. S, we're just going to be here for the ride. So Dr. Bay, tell us exactly why you chose this topic and why you love shoulder impingement so much.
Well, as PTs, I think we're just so passionate about educating the population. And this is one of the most common syndromes that we see. Any athlete that does repetitive overhead movements is subject to experience shoulder impingement at some time frame during their performance or training periods. So it's a fun one to talk about and educate on.
Awesome. So we're going to have fun. That's what we're doing. We're having fun.
That's the plan.
Okay, cool. Dr. Silverton, can you take us through and tell us what shoulder impingement is for our audience?
Shoulder impingement occurs when structures inside the shoulder become irritated or compress during movement. Most of them involve the rotator cuff muscles, particularly supraspinatus out here, as well as the subacromial bursa that sits on top of the joint here. Normally gets squished underneath the acromion right through here.
Awesome. And take us through the important structures also involved in this, any additional structures that we see involved in shoulder impingement.
So with the shoulder, there's a lot of moving parts to it. If any of them don't move as much, then that can be a problem. So you have the main joints between the humerus and the scapula. If we imagine that there's a rib cage right here, scapula is on the backside. This glenohumeral joint can be stiff or not move enough. It's kind of like a ball and socket. You have the collarbone coming into the scapula here, and the joint in between the two here are going to be the acromioclavicular joint. The subacromial space that I talked about is going to be underneath this overhang from the scapula. So you have a tendon that comes right through there. As the humerus comes up, that might squish the tendon right there for whatever reason that may be happening. And then the rotator cuff itself, like I said, supraspinatus is the most common part of it. But you can get impingement in other places, particularly posteriorly as well.
Awesome. The shoulder is so complex. It's one of my favorite joints. So like you said, shoulder pain is multifactorial. And usually it's not just one damaged structure. I think that's the thing that we see mostly. And I think that's why this is such a controversial topic in our field. We call it shoulder impingement because we really don't always know exactly what thing is being pinched on. We see things like weakness in a specific muscle or tendon, and that makes us think, okay, that's the thing that is most irritated and potentially pinched. We might see tenderness in a certain structure, and we're like, okay, that particular structure is involved. Maybe it's the infraspinatus or the posterior cuff that we feel like has some deficits as well. Sometimes we see issues just in irritation or tenderness along the anterior shoulder and the biceps tendon. So and sometimes we just see a combination of a lot of different things. So we kind of lump it in and we call it shoulder impingement because we know things are irritated in there. And we ultimately are going to address it pretty similarly to most things. We're looking to look for the deficits and the impairments and address those things. But it's hard to really quantify or qualify exactly what's happening in here when we have a shoulder impingement. So we're just going after it, though. We'll fix it. We discussed about being multifactorial. It's not always one damaged structure. And then the other thing is, I think that's important, is pain doesn't always equal severe tissue damage, right? So have you guys noticed that, if people have pain, we don't always see that there's a huge problem. Sometimes it's just a small problem when they have pain, correct? And so, that kind of cues us into kind of how we're going to navigate. But it is important to know for us to understand your anatomy. So and address and try to figure out what the problem is so we can kind of go after it more specifically, shall we say. I'm going to go into common causes in athletes that we see. How do we actually get shoulder impingement? So let's talk about some of those reasons. The first one is repetitive overhead activity. So if you play a sport where you do repetitive overhead things like throwing, swimming, serving, like in volleyball, pressing overhead if you're a weightlifter, CrossFit movements, you could be a football player, you could be a baseball player, anything where there's repetitive overhead movement, that it puts you sort of at risk to potentially have some shoulder impingement. If you have rotator cuff weakness, so weakness in your rotator cuff where maybe it's just not strong, it's not stable, maybe it's not something that you often address in your strength training or work in your training as an athlete, and you have a weak rotator cuff, or you develop a weak rotator cuff, that could be a reason that you get shoulder impingement. If you have poor scapular control, that could be a reason. So your scapula, or what we call your shoulder blade, right here, it is a huge foundation for the shoulder for overhead movement. So if you had poor mobility in this scapula or stability, and it's, being the thing that stabilizes the shoulder, one of the things, or you have poor coordination between the scapula and the humeral head here as your arm goes overhead, and if they don't move together well, that could create stress on the rotator cuff and all the surrounding tissues, and that can create an impingement in your shoulder. Another reason that you might have develop shoulder impingement is limited mobility in the shoulder. So if you don't have all of your range of motion, you could not have just true shoulder end range of motion because you don't work that, you don't stretch your shoulders at end ranges. Maybe you have very strong and broad shoulders. You're a weightlifter and you need that, strength in your shoulders, but you don't necessarily need the mobility, so you don't go after that and you don't utilize it. That could be a reason why you develop some impingement. Maybe you have tightness in your thoracic spine. The thoracic spine is very well connected to the shoulder. So if you have some limited mobility there, that could create a problem and also create some impingement in your shoulder. So those are some reasons. Those are the first few reasons. The last couple ones are you could have training errors. So maybe you have a sudden increase in your volume or your load, or your intensity or frequency of how you're training. That could be in your sport. So you just overdo it, or in your strength training, you overdo it or you overload. That can create irritation in those structures and create an impingement in the shoulder. And then maybe you just have some poor movement patterns and you're not lifting correctly, or you're not throwing correctly, or you have a breakdown in some portion of your movement quality. That could be a reason why you develop a shoulder impingement. So for us, as physical therapists, we're going to, look at all these causes and see if there's sort of something that we can do. It could just be that you just made a boo-boo and you just did something wrong and you overdid it, and we just need to educate you, right? Don't do that. And help you get stronger, better, get rid of it, and send you back on your way. But a lot of times what we find is, there is some other, the cause of like how you move and how your mechanics are often contributing. So we're going to take a look at that and try to retrain you and go back through the things and figure out why it developed and retrain your movement patterns so that you don't continue moving that way and you go back to your sport and you're a better athlete for it and you're pain-free for it and you don't have it develop again. So question for you guys. Can athletes be strong but still have mobility deficits?
Oh, yeah.
Yeah? How so? Give me an example, Dr. S.
Let's see. So we have a guy that can bench press, I think close to over 200 pounds right now, but he can't get full 90-90 on it. So you can try to crank, but it just pinches up his shoulder. He doesn't have the flexibility in order to get there, but he's really strong.
Yeah.
Can't deny that he's not bench pressing that heavy.
Yeah. Do you think he needs that mobility at the end range, or do you think he can do what he needs to do without it?
He has enough mobility for the bench press. He doesn't have enough for his overhead press. So if he's trying to get up here, he doesn't have that rotational factor to it. So, and that's kind of what leads him to having shoulder issues also, because he's trying to overhead, but he just can't get to the position to lock out.
Yeah. Any thoughts on that?
Well, my thought is it leads more into the treatment portion, but in general, as PTs, we tend to see our strongest patients need more mobility help, and then vice versa. Our most mobile patients tend to need more strength help, and that's an easy way to simplify one of the ways we approach looking at people.
Yeah. And I think this is key, like Dr. S was talking about, like I see this a lot in our strongman population and our weightlifters, because they work on strength so much, but they don't really prep their mobility and their flexibility. So when they have to do overhead press, they get stuck and they can't get there. And then they try to force it, and then boom, impingement. So if you know you need to overhead press, you got to make sure that you have the mobility to get there, and then work that a little bit first, then start overhead pressing and moving your weight. And so it's just training. It's like if you need that thing, you got to train it a little bit before you force it. So yeah, so it's good discussion stuff, good stuff to discuss together. And maybe things that you guys have noticed or experienced. You're like, I'm strong and I should be able to do this, but I keep having this problem. That might be why. All right, Dr. Bay, take us through some symptoms. If someone had shoulder impingement, what might they commonly either feel or say they feel, or describe it, or tell me some symptoms that we see.
Yeah, so a patient that presents to us with this syndrome is going to be reporting that when they're doing overhead activity, they're having pain, pinching sensations in the shoulder, weakness or loss of strength, and a big one is pain sleeping on their affected side, and sometimes on either side, to be honest. And they're definitely going to say things like, oh, I feel a sharp pinch in my shoulder. I have weakness when I'm trying to perform overhead. After I train, my shoulder's really sore after, and that lingers. I don't have the same kind of power I used to move my body or to press weight overhead. And then my recovery is poor. Those are all very common things that they're going to talk to us about. Next is kind of more, did you want to say something?
No, you're good.
Is what, as clinicians, I think that we are looking for is these correlations between their movement and their symptoms, and also their compensation patterns. So for example, when we're evaluating someone, we're going to try to figure out which exercises reproduce the symptoms. Are there certain positions that are more likely to cause their symptoms versus others, and certain phases or timing of the movement and timing of the shoulder and the scapula that would reproduce their symptoms. Then also how they're compensating. Are they performing continuously with altered movement mechanics? Some people subconsciously just keep going, but have started to keep their arms lower and lower and lower, or they've just stopped moving certain parts of their body so they can keep going, they think, which is a good thing, but really now they've disrupted their movement patterns even more. These are really tough things that happen in this process.
Awesome. Thank you. When do you guys think athletes should seek treatment with shoulder impingement? At what point do you feel like they should get help? Thoughts?
If they've already tried the whole backing off, deloading, and then gradually getting back into it, and then they still get bit in the butt and they have recurrence of symptoms, that's probably a really good time if they've tried the other things that are simple, where it's like, hey, back off and then try it again, sort of thing. That's normally when people start coming in through our doors.
Yeah, that's good. Yeah.
That's a good time to come.
Yeah, I agree. Yeah.
Don't wait longer.
I would just say don't let it go too far. Like don't let it go, 4 weeks, 5 weeks, 6 weeks. Honestly, there's like just things we can give you to do right away that are going to make a huge difference in your training. So I agree with Dr. S. If you know how to deload and go back that, if you don't know what to do, just get some help right away. You'll be better for it, and you'll save yourself like some long-term issues, or just, having to change your training for a long period of time, or miss a competition, or miss things you want to do. So yeah. All right, Dr. S, let's talk about assessment. If someone has shoulder impingement and they need some physical therapy help, what can they expect if they come and see us for the first time and get a physical therapy evaluation?
First and foremost, we look at their mobility, their strength, their coordination, and the quality of their movements. Yes, there are tests where we can localize the pain to whatever particular structure. They'll come in with x-rays or MRIs, but that tells us, okay, the ouie's right there, but what led up to it in the first place? What kind of movement deficits that led into that? Because a lot of times this is becomes a chronic thing. And it may have been brewing for a bit before they started revealing any sort of symptoms, or if they up their levels, then they might be contributing to that. So we'll look at the strength of their rotator cuff, but not only sometimes they're really strong in the rotator cuff, but they're weak in their scapula. Sometimes they have the strength overall, but they don't have the endurance to match up with whatever their activity may call for. So if you test them at the moment, they're fine. But if they're swimming the longer distances than they're doing, then their technique starts to break down just because of the endurance issues. Mobility, what I normally go look at first is, can they move their thoracic spine? That's a big one for me. Posterior shoulder mobility is a common area to go after as well. Chest flexibility, are their pecs really tight? Do they live with slumped shoulders, and can they even bring their shoulder blades back in the first place? You'd be surprised at the people where I'm just teaching them, hey, squeeze your shoulder blades back, and they start lifting their neck or arching their back, or just pulling their elbows back instead. Overhead mechanics is everything moving upwards. Shoulder blades, not just the arm bone, but the shoulder blades as well, and the chest coming up. Taking a look if we're at that point where we're not having to worry about their mobility or strength with day-to-day sort of things, and we'll up the ante and say, okay, show me how you pitch, show me your backstroke, show me your bench press, and then we'll take a look at how that looks as well. And if there's any breakdowns in technique, then we'll address those too.
Awesome. Do a lot. It's a 75 to 90 minute evaluation, and we're doing a lot in that time. So we don't always look at everything that first day, that we look at everything that's going to matter right away for treating you. But this is something that we will make sure that we're assessing as we need to assess over time. For example, if you can't lift your arm up in the air, we're not looking at your throwing mechanics, right? That day. But we're going to assess the things that are important. We're going to make the assumption you can't throw because you can't lift your arm overhead, right? But sometimes you come in and you have a lot of these things, and we're just going, okay, let's look at your throwing mechanics. Let's look at how do you swim? How are you backstroking? We might be going to the higher level point of this, because just because you have the problem doesn't mean you can't do a lot of things. And so this is one of those injuries where you could be at any kind of point in that continuum where it's very beginner and you can't do a lot, or you can do a lot, but you just keep having this nagging, pinching pain at your end ranges. So really good. A lot of people might have the question about imaging. Is there a reason why you guys think that imaging doesn't tell the full story with this particular injury? And if someone got, let's just say, an x-ray or MRI, they might not see too much on there?
If they don't see much, then it's probably pretty early on in the scenario. So it could, because the X-ray is just a picture of you in one point in time, and not you with your arm over your head, particularly. So things may not show up like that as far as like the pain. If it's an MRI, then it'll just show you where it's inflamed, but it doesn't really tell you why it's inflamed in the first place. And oftentimes it's not even inflamed. It's just degeneration of the rotator cuff tendon, and that's happened over time. And yeah, sure, you have a tear, but I think, was it 80% of rotator cuff tears are non-traumatic? It's just something that has been brewing over time until they do something and their shoulder starts to hurt and they can't lift their arm.
Yeah, it's a great answer. Yeah. You have any thoughts?
Well, again, just imaging shows us where the owie is, but not why it happened, right? Yeah. So it's not going to show us that their shoulder blade doesn't upwardly rotate enough when they bring their arm overhead.
Right.
But we have to figure that out with our testing.
Yeah. And I think that's why individual assessment is so important, because it really does depend on, are you a, football player? Are you a swimmer? Are you a weightlifter? Like, depending on what's going on, people will ask us a lot of times, like, what do I do for this? And it's just really hard to give advice like that without actually taking you through some of the movements that are involved and really even getting objective testing on some of those movements, using dynamometer, using force plates and things like that. So it does really require, individual assessment if you really want to have some valuable feedback and valuable guidance with this injury. So yeah, good stuff. All right, let's go into recovery and rehab. So take us through the rehab process, Dr. Bay. What actually happens with someone who has shoulder impingement? What are we doing with them here in physical therapy?
Yeah, so there's several ways we approach this. And as we brought up, we love to educate. So the first thing we're going to do is help patients modify activity. We're going to be providing interventions for mobility, strengthening, neuromuscular control, and then we'll put it all together with movement retraining. So to help the structures heal, we're going to coach patients on how to stay away from aggravating activities. And that does not mean at all that we want you to be a couch potato. We want to encourage continued training, but we might be limiting things such as volume, load, or which ranges of motions you're going to be working in this time where we're trying to get the pain under control. And then during the early phases, it focuses probably a little bit more on our mobility intervention so that we have full range back. And that kind of the structures Dr. S was talking about during the evaluation portion, we're going to be really looking at, does your thoracic spine extend enough so your arms can get overhead? How is the mobility of your chest? Can we get your shoulder into a neutral position? Is our posterior part of our shoulder mobile enough, again, so our humerus can sit where it needs to sit on top of the shoulder blade so all these structures can work together to stabilize the shoulder? And a lot of times that requires manual therapy and both therapeutic exercise for those mobility interventions. The strength portion is super important because the shoulder is such a mobile joint. It needs lots of strength to stabilize it. So that's when we work on our rotator cuff strengthening, our scapular stabilization, providing that endurance, as he said, so that we can make it the entire length of the time that we need to perform in our sport. And that we coach our patients on how to slowly, progressively load the structures so we don't get re-irritated again during this process. Very, very important is our neuromuscular control. We must teach the shoulder how to stabilize. We must improve its coordination and then continue to build the complexity of the movements from simple to more difficult and then sport-specific, maintaining the stability and good mechanics while doing so. Then we put it all together. We work on our movement retraining. When we first assessed you, if you came in with poor lifting mechanics, we're going to spend a lot of time making sure you can do your cross training, or if lifting is your sport, lifting properly. We want to make sure your shoulder blades are moving along with your humerus through the full end ranges. Your spine posture is creating ideal placement of everything to work together. We want to re-educate how you move overhead. We want to do sport-specific progressions, all of that good stuff.
That's good stuff. Awesome. What are some things you guys think athletes do wrong or may make mistakes within the rehab process? What are some things, not the return to sport process, but just the rehab process? What do you guys see athletes doing wrong, potentially? Anything?
They'll rest, and then they'll just go right back to doing stuff like what they were doing before.
Yeah.
And they're like, oh, it doesn't hurt. And then they go back to doing it, and it's like, oh, it hurts again.
Yep, it's a good one. Anything from you, Dr. Bay?
I mean, I think we're just very thoughtful in how we progress patients, and they just, again, think, I'm feeling better. I feel like I want to try something. Mm-hmm. So not that we can't get better. We just have more setbacks along the way. Mm-hmm. Yes. So I just encourage a lot of discussion with your PT.
Yes.
Yeah.
I'd love to try this next. Can I do it? And then it'll either be yes or, well, let's try this step first.
Yeah, absolutely.
Yeah. Normally, if they can jump right back into it, they're not coming in. But if they have jumped back into it and it doesn't work out, then they got to do little baby steps to get back to it.
Yeah. I'm a stickler for this, and Dr. Bay too, I think. So it's like, talk to me about what you want to do. Talk to me what you're going to do. We can talk it through. I'm not always going to say no, but let me guide it. So I can be like, okay, let's try it, or let's see. I think sometimes with the PT athlete, PT patient sort of relationship, it's like, okay, they're going to stop me from doing what I want to do. Ultimately, we want you to do what you want to do. We just are kind of like, we want to prep you. Okay, this might go well, but this also could have a problem. I want to make sure you know the risk. So it's basically your decision to make. I always say this is your ship, and you're the captain of the ship. We're just on the ride. We're here advising and guiding you. It's your decision to make as an athlete, but we want to help you not have a reoccurrence or a setback or anything like that. So our goal is to just make that ride smoother. So yeah, that discussion is really important. I think those conversations are really important. And sometimes we have setbacks. Yes. Okay, good. That's good stuff. I'm going to take us through the return to sport process and performance. So we'll dive into that. In order to return back to sport, typically what we do here at PTSP is we try to take our patients through some return to sport criteria. That includes strength testing. So we're looking for symmetry between your right and left side. We do know there is going to be some level of asymmetry. We use research-based metrics to determine what that is. We're not always going to have perfect symmetry between your right and left sides, but we're trying to get fairly close and using research to guide us with that. We want to make sure you have full mobility, so you can move your arm fully overhead. You can move in all directions. Sometimes you don't get all your mobility. You don't need it all to do everything, but we're trying to get pretty close to having similar mobility to the other side. Neuromuscular control. Can you move well? Is it coordinated? Can you stabilize? Does it look pretty? Do you have control through your movement? We want that. We want you to be confident when you return to sport. You need to be confident in going back. If you're not ready, we can't send you back. You're going to get re-injured. So it's really important you feel confident in doing all the things you need to do. And then you need to be able to tolerate your sport-specific things, sport-specific tolerance. So we need to make sure that we've gone through all the sport-specific skills with you, depending on your sport, and trying to recreate as best as we can the exact things that you have to do in your sport, and ensuring that you have the endurance, like Dr. S said earlier, to do those things. It's not just about doing them, but can you do them for the time that you need to be able to do them. Sometimes that's us telling you, okay, I want you to go, say you're somewhere, go get in the pool, swim 100 yards, swim 400 yards, depending on what you need to do, the stroke you need to do it in, and coming back to us and saying, how'd that go? Okay, let's add more. So some of the things aren't in the clinic, but us guiding you through those things in your sport before we fully get you back to full return to your sport. We want to make sure that we're doing gradual progression through those things. So we're gradually progressing your loading, your volume, your intensity, and we're just going to be helping you manage your full workload. So we use things like a workload calculator here to do that if we feel like it's important, to make sure that we're just not adding too much load too quick. And yeah, that's pretty much how return to sport clearance goes. We take you through all the tests, we clear you, and then we slowly get you back into some of the skills that you need to do. I think the key takeaway and what we already discussed is that pain-free doesn't always equal that you're prepared. So it's really important. This is the phase where I feel like if we're to talk about what athletes do wrong, I just feel like they don't stay until this phase. I feel like a lot of them get pain-free, they get their mobility, they feel pretty strong, they go back. But this is the phase where we really do like the heavy sport-specific work and skills work. And so this is the most important phase, in my opinion, at the very end, making sure you're good to go. So I would say don't skip this phase, stick with it. And if you don't have a PT that does these things, find someone. We all have a ton of athletes that come see us. They do rehab elsewhere because maybe their insurance doesn't cover and pay for us here, or they'd have to pay a higher out-of-pocket cost to see us. So they go somewhere else and do rehab, and they come here for the return to sport piece. That's fine too. You can find a place that does return to sport training that has sport-specific therapists. Do that. It's smarter to make sure that you're ready to go back to sport, especially if you're trying to go to college or play professionally. You just want to make sure you're fully ready to do that. So that's what I see. Is there anything else you guys see? I think you guys see the same things that I see in terms of this phase for sure. Let's talk about prevention as a team together. What are some things you guys think that athletes can do to prevent this particular problem, a shoulder impingement? What are some things they can build into their lifestyle, in their sport, in their training, all those things?
I would start with an individualized warm-up.
Okay, proper warm-up. We love warm-ups.
Not just whatever your coach takes you through.
Yes.
That's what I mean.
warm up is controversial too. You don't have to warm up all the time for everything, but you need to check in with your body frequently on some things. So, are my hamstrings tight today? Or am I, so with shoulders, we're going to go, are my lats tight? Do my pecs feel tight? Doesn't mean that every time you go like train, you have to stretch your pecs, you have to stretch your lats, but it's important to check in and warm up things. So that's kind of what we mean by warm ups. Dr. S, any thoughts? What are some things they can do?
Maintaining strength during the off season, or build strength during the off season, and when you're in season, have some degree of maintaining that strength throughout the whole season too. A lot of times when they get into season, they get really busy with games and things like that. So I'll typically tell people, divert resources towards your games and your performance. But one day of weight training for the shoulders would probably still be a good idea. And most coaches will incorporate that, but if people are out on their own, say they're doing like CrossFit or something like that, or high rocks training, they may not have coaches that are guiding them before the competition. So, and then, or even golf or anything like that. Some degree of maintaining strength outside of just doing the thing that you want to perform at.
Yeah. And when you say strength, I was thinking specifically like your rotator cuff and stability strength, because I think that, athletes that play overhead sports, they do chest press and lat pull downs and rows and planks are actually good for shoulder stability, but they don't specifically train the rotator cuff. It's so heavily involved. So the rotator cuff needs to be a part of, I think, your strength training if you're doing repetitive overhead work. And stability training, side planks, things that, high planks, things that are, and maybe making those things more challenging for you, but things that really work on your shoulder stability as well. It's kind of, it can be missing from athletes' training programs. So I would say specifically those things are important too. I think they get missed. Yeah. Any other thoughts from you?
Well, how about our recovery and sleep?
I knew you were going to say that. So predictable.
Dancers typically don't fall in the shoulder impingement category. Some gymnasts do though.
Yeah.
But a big thing is after working really hard, we got to cool down properly, and we have to prioritize sleep. That's where our body recovers.
Yeah, absolutely. Any other things you guys would say? I really like to make sure that I implement or educate my athletes to do this when we graduate them. Anything else you can think of? Okay. I think that's it. Unless you guys have any other final thoughts on this topic that you want to share. Any sauce that you are keeping within you that you feel like can be given?
Oh, I would never hold that back.
Okay, good.
I want everyone to be able to get help.
That's right. Well, ultimately, we want to help you and make sure you guys feel good. So
if you don't think it's progressing in a forward manner, please come to see us or someone and get help.
Absolutely. Yeah. If you're dealing with, specifically, if you're dealing with shoulder pain, shoulder impingement, please get some help. We would love to help you. At Physical Therapy San Pedro, we treat patients in the clinic. We also see patients via telehealth, so we can treat you anywhere in the world. So if you're needing some help, reach out, DM us, contact us. You can reach out to us on directly by looking us up, Google, Yelp, or you can look up our social media pages, Instagram, Facebook. We're a little bit on TikTok now, YouTube. We have 67 previous videos on YouTube with all of our episodes going over several different topics. We're at the shoulder now. We started at the feet and the ankles, and we're up to the shoulder. So we only have one more area to go. So go check that out. We're here to educate you guys and give you guys some information on topics we feel that you as athletes, coaches, trainers, chiros, physicians, anybody who wants to learn about these topics can go do that. You can also listen to our podcast, the Physical Therapy San Pedro podcast. So if you don't like to watch and you want to listen, put that on in the car. You can ride along and listen to what we have to say and get some education there. I think that's all I have for you guys. So stay tuned for our last shoulder topic, which I'm not going to give away. You just have to come back and see. I'm writing that blog and doing that one. So we'll finish on the shoulder, and we will see you guys next time. Bye.